Good afternoon, everyone. Herewith, I welcome all our respected speakers and respected dignitaries. Dr. Mahadev Desai, sir, the Director of CGP, IMA, GSB, Dr. Jaswant Singh Darbar, sir, Dr. Kakaria, sir, the President of the IMA, GSB, Dr. Mehul Shah, sir, the Honorary Secretary of the IMA, GSB, Gujarat State Branch, and very senior pediatrician who is very keenly interested in the Chandipura virus infection is from the Rajkot, our respected Dr. Yagnesh Popat, sir. Now, before I invite the first speaker, I would like to invite Dr. Yagnesh Popat, sir, to say a few words regarding this CME. Please, Popat, sir.
Yeah, thank you very much, Dr. Dinesh Gohil. Good afternoon to all. Respected organizers, Dr. Jaswant Singh Darbar, Dr. Dinesh Gohil, Dr. Dhiren Mehta, and our respected senior advisor, Dr. Mahadev Desai, sir. Today's faculty, Dr. Abhay Shah, and a special in our guest from GMERS, Himmatnagar. Friends, today we will be having a word about the Chandipura virus. Though it is not a new virus, it has recently upsurged its activity. And why we are worried about this virus is not because of the number of cases, but because of the case fatality percentage, which is very high in this case. So without wasting much time, because our guest faculty is very keen to advise us with regards to the clinical diagnosis as well as the management of this virus, over to Dr. Dinesh Gohil for further proceeding.
Thank you, Popat, sir. Now, I would like to invite our first speaker, Dr. Hardik Bhavsar, sir. Dr. Hardik Bhavsar, sir, is the professor and head of the Department of Microbiology. Also, is working with the Additional Superintendent of GMERS Medical College, Himmatnagar. And today, he will be speaking on overview of Chandipura virus and laboratory methods of the diagnosis. So, Dr. Hardik, over to Dr. Hardik Bhavsar, sir.
Thank you very much, sir. I hope I am audible to everyone.
Yeah.
Thank you very much. I heartfully extend my gratitude to the entire team who has invited me to share my experience and thoughts and little bit of knowledge on this Chandipura virus. And I will like to share the details of the virus, at the same time my personal experience during this episode of ongoing Chandipura virus epidemic. So I'd like to share my presentation on that. Is my presentation visible, sir?
Yes, sir.
All right. So in this short talk, the objectives I am going to cover are...
Sir, full screen kar do. Full screen kar do.
Hello, pardon, sir?
Full screen kar do. Computer ma full screen kar do.
All right. Let me see. I don't find... I can see the list of the members on the right side. Is the presentation not visible, sir? Okay.
Sir, go on. No problem.
Yeah, thank you, sir. Thank you. All right. So the objectives I'm going to cover in this short talk is a little bit of introduction of what's going on, the chaos going on right now, the history of this virus, a little bit of the morphology and life cycle, and at the end, the laboratory diagnosis, and what are the effective things which we as microbiologists doing as a part of this laboratory diagnosis chain for this particular virus. So this is the headline of yesterday's Times of India news, which shows that Chandipura virus spreading its wings and claims 32 lives. And children are the most vulnerable. Not the most vulnerable, almost all cases are children only, and 32 lives being claimed by a virus in such short span of time is definitely a big thing. And that is the reason why we have gathered here and we are talking about this virus, because innocent children are dying of acute encephalitis, and the vesicular virus named Chandipura virus is the one to blame. So Chandipura virus is a vesicular virus belonging to the rhabdovirus family. I'm going to talk about it later in this talk. If we throw some light on the history of this virus, so this is not a recent or a new virus. Of course, we can say that it is an emerging
to move the slide.
infection. Pardon, sir?
You have to move
Change
the
the
slide.
The slides are not changing and it is not in a full mode.
So on my screen, the slides are changing perfectly fine.
Yes.
Now, is it okay?
The slides has changed, but it is still not in a full mode.
No, I don't know,
Slideshow
sir,
mode.
how to get to this full screen mode. I'm not well versed with this.
No issue, it is visible.
Yeah, thank you for bearing with me, sir. Thank you.
Okay.
So this is not a new virus. The first isolation of this virus was from the case in Nagpur, in a village Chandipura in Nagpur district back in 1965. But because this is a sporadic infection and very few cases comes up, so it has never gained an attention globally. But it gained that global attention in 2003-4 outbreak, where we had total 322 child deaths, out of which 183 were in Andhra Pradesh, 115 in Maharashtra, and 24 in Gujarat. So that was the episode when this virus came up as a huge threat of being an encephalitis virus, specifically in children of 0 to 15 years of age. Now, if we talk about the morphology of this virus, it belongs to the genus vesiculovirus and family Rhabdoviridae. This Rhabdoviridae family has another very well-known encephalitis causing virus, that is rabies virus. That
Move
is
the
one
slide,
virus
please.
about which we have.
Move the slide.
Pardon, sir?
Move the slide. It's not moving.
Sir, I don't know what's going on. I am moving the slide, but somehow.
Yes.
Yeah, it has changed now.
Yeah.
Sir,
Now it
could
has
you-
changed. Go on, sir.
Fine. So it belongs to the family Rhabdoviridae family, and one of the member of this Rhabdoviridae family is rabies virus. That is also an encephalitis causing virus, and probably we know that virus pretty well compared to this Chandipura virus. But for the reference, you can consider that many things are quite similar to that rabies virus as far as the morphology is concerned. It is an enveloped virus containing a single-stranded RNA. Usually, we classify the virus depending upon envelope and non-envelope, the genetic material, whether it is a DNA virus or RNA virus. And when we talk about the RNA virus, whether it is a positive sense RNA or negative sense RNA. Positive sense and negative sense RNA is a core microbiology subject that decides how the virus is going to replicate its genome in the host cell. So clinically, it doesn't make much of a difference, but just for the basic information, it is the negative sense RNA virus, and the genome code consists of mainly it translates of 5 major polypeptides of this virus. Now, why these polypeptides? It is important for you to be well versed about only the names of these polypeptides. Is we have seen that during COVID, almost every physician knew what is the target of the RNA. Of the RT-PCR they are asking for from the lab, and depending upon that, they used to decide the authenticity of that RT-PCR and the trueness of the report of that RT-PCR, that how many targets the RT-PCR has covered. So here also, there are 5 main polypeptides of this virus, that is nucleocapsid protein N, then phosphoprotein P, matrix protein M, glycoprotein G, and large protein L, out of which glycoprotein G is the anchor capsomer sort of thing on the outer surface of the virus, which helps the virus to attach to the host cell. I'm sure you can correlate many things, many technical things with the COVID, because we have quite thorough knowledge of COVID, whether we are all physicians, pediatricians, surgeons, we all have thorough knowledge of coronavirus, SARS-CoV-2. So these glycoprotein G is one such structure which helps the virus to attach to the host cell. Okay, so this is the basic of morphology of this virus. Now, life cycle, when I say life cycle of the virus, basically I talk in 2 terms. One is the life cycle in the community. That is more important because everybody is more interested in knowing that from where the virus comes. What we know by now, by reading the various articles in the newspaper, is that the sandfly bite causes the virus or the infection. But what is before that, what is after that, we usually don't know. So there are 2 life cycles. One life cycle of the virus is the life cycle that virus has in the host cell. Right? So that how one virus is multiplied into many viruses in the host cell. That is one life cycle, which I'll show in the next slide. And this is one life cycle which is important from epidemiological point of view. And that life cycle shows, if you pay attention, there is one blue arrow shows that from unknown reservoir, the virus is taken up by sandflies, mosquitoes, and ticks, mainly the sandflies. Everybody knows that the phlebotomous sandfly is the main culprit or the main vector which transmits the virus. But it transmits the virus from where? It transmits the virus from many reservoir animals. So it transmits the virus when the sandfly bites that animal, it sucks blood of that animal and contains the virus. And when the same sandfly bites a human, usually, so we can say that this is a zoonotic infection. So human is usually the dead end for this cycle. But once the human is bit by this sandfly, and in some cases, some mosquitoes as well as ticks also, the Chandipura virus is introduced into the human, and there starts the life cycle of the Chandipura virus within the human. So if I just read out these slides, phlebotomine sandflies, which are found in the crack of the wall, where they breed and lay their eggs, and the mud houses. These are the areas where we find the sandflies. Another such vectors are the mosquito species, for example, Aedes aegypti, which is also a vector for dengue, and they are said to be the vectors of Chandipura as well. But right now, our focus and the focus of the entire state machinery is to identify the sandflies, and they are targeting the sandflies only. But this also can be the cause. That's why I have covered this part. Then we have the life cycle in the host cells. That is the second half of the life cycle. That once the human acquires this virus, then what happens? So there are few important steps. I'll just go through them. First is the attachment. As I told you, the G glycoprotein is the receptor by which it attaches to the host cell in the humans. Once getting internalized, there is endocytosis. Once it is internalized, there is decoding of the virus, and whatever genetic material inside the virus is free in the cytoplasm of the cell. There are few core microbiology steps which take place. That is the primary transcription. By primary transcription, there are few amino acids. The mRNAs are converted into few proteins, and that is few amino acids are generated, which cause for the production of new G, M, and NPL proteins. And at the same time, some of the RNAs, they go into the genomic replication, and multiple copies of the genomic replications, due to genomic replication, multiple copies of that RNA are formed. So those copies are there in the cytoplasm. The protein is made in the cytoplasm through the translation, and then there is assembly formation of the virus, and through budding of the cytoplasm, the newly formed virus is released. So in nutshell, through these 4 or 5 routine steps of the viral replication cycle, the virus is formed through the new viruses are formed through the host cell. Now coming to more important area, that is the laboratory diagnosis. Now, if I share my experience from government institute point of view, when we say laboratory diagnosis of Chandipura virus, we know that it is not a routine virus laboratory test that is performed in the laboratories, right? Even in the highest end laboratories of the state, these tests are not performed. The reason is that this is a sporadic disorder, and no commercial kits are available in the market to perform this test. So we have to send the sample to the referral center, and there are two referral centers at the level of Gujarat. This is the last slide, but I'll show you first. There are two referral centers. One is the National Institute of Virology, is situated in Pune, and the other one is at our Gujarat level, that is Gujarat Biotechnology Research Center, GBRC, Gandhinagar. These two are the centers where the laboratory diagnosis of this Chandipura virus can be performed. Now, what are the modalities? If today only I had a team from NIV Pune in my institute, they are already there and meetings are going on. So when I discussed with them, I got to know a few more things than what I already knew by reading this paper. One thing is, from serum, they do IgM detection. That is a serological test, the only serological test that is performed for the detection of Chandipura infection. More emphasis is on the RT-PCR. Now, in RT-PCR, they have a real-time RT-PCR, and they target the 527 nucleotide N gene. That's why I told you those 5 genes, that they are targeting the N gene for identification. The sequence of this N gene primer has already been published so many times in many papers also. But as I told you, there is no use of developing this primer commercially, so it is not there. They also grow the virus on Vero E6 cell line. They also use animal models for animal inoculation and identifying the growth of the virus in, say, for example, they take 1 or 2 days old mouse, and they see for the growth of this virus in the brain tissue of that mouse. And he discussed the entire cumbersome process of that thing, which is again a core microbiology subject. They may not interest many of us, but that is one modality. And yes, gene sequencing, which is coming up as a very interesting and very useful tool of laboratory diagnosis of many viruses, as we see many mutations in existing viruses and many viral infections are emerging. So this gene sequencing, yes, they are performing. So using all these modalities at different levels, depending upon the clinical condition and requirement, the NIV Pune provides us with the report in 2 terms: IgM detection. And again, when we send a sample for acute encephalitis, they don't only focus on Chandipura virus. They include 3 more viruses. For encephalitis, they give report for the Chandipura virus, enterovirus, herpes virus, and Japanese encephalitis virus. So that is, they call it as a encephalitis panel. So these 4 viruses they detect using this RT-PCR technique. And we received this letter from the state government that for almost a week now, GBRC is also performing these tests. So now we are supposed to send the samples to the GBRC. Now, talking about the samples, what are the samples that we have to transport? The samples that we send is CSF in the sterile container, serum in the plain vacutainer, nasal and throat swabs in viral transport medium, and sterile urine sample. We have to ensure the maintenance of the cold chain and triple packaging. We all are well versed with the triple packaging system, so I'm not going into detail with the triple packaging system. One last point, you may be intrigued to know why I have included nasal and throat swabs in VTM. So this is again an email that we had received, that because they want to exclude enterovirus as well, they want to have nasal and throat swab. And as a part of surveillance, NIV Pune asked for these samples as well. So now we are sending all these samples. I hope in a short span of time given to me, I tried to cover as much information as can be handed to you and can satisfy your curiosities. Thank you for giving me this opportunity, sir.
Thank you, Dr. Bhavsar, sir, for such a beautiful and informative lecture.
Thank you, sir.
Literally, this is a second impending life-threatening risk on the humankind. So, thank you very much, sir. I think you're not going to stay, otherwise we'll invite you for the question-answer session just now or after that.
Sir, I'll appreciate if I can attend few questions right now because I have to go and attend that meeting I was talking about.
Okay. So to the audience, sir, if you have any question, then please come forward to ask.
Sir, what is the incubation period for the availability of the virus in the media?
Sir, if we talk about only Chandipura virus, the incubation period is very short, sir. It may be from 1 to 3 days.
Okay, so after the first symptom, actually we are supposed to send the patient for the investigation for the sample.
Yes, sir. When you receive a patient whom you suspect as a case of Chandipura virus infection, without failing, the first thing you have to do is collect the samples because it is difficult to say, but it is a fact that you may not get a chance to collect a sample from a live case.
Yeah. Thank you.
Because the mortality is very high, sir. Very high.
That is why I am asking you, because whatever we try on the very first or second day to control the fever, but if there is a Chandipur virus, then it may create a very problematic to the patient. No?
Yes, sir. If you suspect CNS involvement, I'm sure pediatrician colleague will throw more light on that. But if you suspect CNS involvement, I'll recommend at least you collect the sample.
Okay. Okay. Thank you, sir.
Thank you, sir.
What is the sensitivity and specificity of this particular IgM?
Sir, serological test, it's a tricky question that you have asked, and it shows your seniority, sir. So, yes, sir, serological test will always have that problem with the sensitivity and specificity. Though I haven't had my hands on these kits, so I don't know the exact literature they have not shared with me. And on asking the same question to NME Pune, they have also not given any specific one-word answer, sir.
Anyone? Any more question, please? Okay, so now, thank you very much, sir, for such a beautiful and informative lecture. And thank you very much for sparing some time for us in your busy schedule. We know that the team is waiting for you.
Yes, sir. Yes, sir.
But
Thank
yet,
you, sir. Thank you.
I would speaker, Dr. Abhay Shah, sir. Let me give a brief introduction about Dr. Abhay K Shah, sir. He is the senior pediatrician and consultant in pediatric infectious diseases, Ahmedabad, Gujarat. He is the past president of Academy of Pediatrics, Gujarat State. He is the national president of Infectious Diseases Chapter of India, 2015, and his special interest in infectious diseases and vaccinology. Today, he will be speaking on fever and CNS manifestations in children, special reference to the Chandipura virus encephalitis. So now I would like to invite our second speaker, Dr. Abhay K Shah, sir. Please, sir, over to you.
Yeah. Are the slides visible?
Yeah, it is visible.
Okay.
No, sir.
Okay.
Okay, now it's fine.
So, good evening, everybody. At the outset, I take this opportunity to thank organizer, especially Dr. J.P. Darbar, our close friend and close colleague from Himmatnagar, where we practice jointly. And of course, I am a headquarter for giving me this opportunity. Now, the ball has been rolled by the previous speaker in terms of the basic structure of the virus and what the microbiologists can help into it. And I'm going to talk on the clinical perspective. See, Chandipura virus is just a havoc that we are facing now. But at the same time, for majority of the virus, except like herpes simplex virus or few viruses, there is no antiviral treatment. And as there is no antiviral treatment, we need to emphasize as a general perspective, the large spectrum, when a child comes to you, with a fever with CNS manifestation. And let me start with this as preamble, a prototype case that we have a 12-year male child who has been vaccinated as per our government program, has a very short history of fever, 102, 103 for 5 days. There is an acute febrile illness, and the child now starts vomiting 4 to 5 per day, which is projectile non-verbal. So here the vomiting is projectile. The child is so sick that there is a decreased oral intake. He is not interested in playing or in the surrounding, and now remains sleepy, irritable sometime, and since last 1 day has started some irrelevant speech, and it is followed by convulsion, which is generalized tonic-clonic, with uprolling of the eyeball, frothing of the mouth, lasted for 5 minutes, and control with lorazepam. So I think this is the very prototype case which almost every physician in his OPD, IPD, emergency room or ICU will come that this is the febrile child who has got the CNS manifestation. Now, if you look at this, the findings, the child was having an altered sensorium. You can see that there is a marked tachycardia, high-grade fever is there, plantars are extensor. However, the meningeal signs are absent. So when the meningeal signs are absent, I'm pretty or reasonably sure that probably we are not dealing with a meningitis. And as there is an altered sensorium, as there is an irrelevant speech, as an abnormal behavior, I can definitely from the clinical ground, without any investigation, without any imaging, I say that yes, I am dealing with some encephalitis or encephalopathy. Means there is involvement of the cerebral cortex. So as a general physician, as a primary healthcare center or as a primary health provider, we need to find out, are we dealing with meningitis or encephalitis? Having said that, now we have got the different terminology. We previously said that this is the child who has got the fever with CNS manifestation. Then in the textbook, we used to say that, oh, is a case of febrile encephalopathy. But now there is a new term that is described as acute encephalitis syndrome, popularly described as AES. And this term has been coined by WHO in 2006. And it has this definition has a many important components which are clinically relevant. There is no need for any laboratory workup or no any. So even a person who is working in the remotest remote area of the Hindustan, they can that, yes, I am dealing with a case of encephalitis. So what is that? A person of any age. So even a newborn to even a 70 years old child. So a person of any age who has got the any time in the year. So irrespective of the season, has an acute onset of fever with at least one of the following, means change in the mental status, inability to talk, a new onset of seizure, which is not equivalent to febrile convulsion. You know that febrile convulsion is not a encephalitis, it's a benign condition. So a new onset of the seizure, and sometimes there may be irritability, somnolence, or abnormal behavior, which is greater than the degree of fever. Means the child looking abnormally dull or the child looking abnormally irritable in reference to the height of the fever. Sometimes during fever, child may become dull. During fever, child may become irritable. But this irritability or the dullness is out of proportion to the degree of fever in terms of duration and in terms of its gravity. That is the definition of acute encephalitis syndrome. Now, if you look at this spectrum, this is the CNS infection, or it may be a non-infectious condition. In that, we have got the meningitis, encephalitis, and brain abscess, or it can be a non-infectious condition like autoimmune encephalitis, or when the fever is present in a neurological condition. It does not include febrile seizures, but at the same time, sometimes there may be a febrile complex seizure where the repeated convulsion occurs within 24 hours. Sometimes seizure which continues more than 15 minutes, and therefore these cases often require the diagnostic workup like that of the AES. So by and large, they are the CNS infection or the non-infectious, they are included in the spectrum of AES. So as on clinical background, when the child has got a headache, photophobia, and meningitis signs, probably the chances of getting meningitis is more. Similarly, when there's altered consciousness, convulsion, some speech problem, irritability, delirium, or memory loss, then probably it can be a encephalitis or encephalopathy. So these are the simple terms. That's it. And on CSF vaccination, that in case of pathogenic meningitis, we have got thousands of cells, which is mostly neutrophilic reaction. Whereas in case of TB, you can see that there are the cell counts in the hundreds, and mostly they are lymphocytic. But in India, it is very difficult to get the child who has not received any antibiotic. Rationally or irrationally, usually patient comes with the to multiple courses of antibiotic, and therefore this full-blown book picture we usually not get, and what we in general get is a partial septic meningitis, where again the lymphos are more than the poly, but your sugar is going to be low because of the pathogenic response. So I think this is in nutshell that how can we differentiate clinically from the pathogenic meningitis from the TBM from the CSF point of view. Now, if you look at this term, that encephalitis means there is inflammation of the brain. So it's a pathological term, and it is strictly a pathological diagnosis, but surrogate clinical imaging markers may require. As against this, the encephalopathy is a clinical syndrome of altered mental status, which is often manifesting as reduced consciousness or altered behavior. Now, this encephalitis can cause encephalopathy, but in some time, the encephalopathy means the brain dysfunction can occur even in absence of the brain inflammation. And here we have number of causes like metabolic encephalopathy, hypoxic encephalopathy, toxic encephalopathy, like our poisoning, uremic encephalopathy, hepatic encephalopathy, so and so forth. So in encephalopathy, the cause may be inside the brain or the cause may be outside the brain. In encephalitis, there is basic inflammation of the brain. Now, if you look at our epidemiology of India, I have put some of the red marks. That is Japanese encephalitis, enterovirus, and herpes. See, all these three now government has included in their screening. When the child comes with AES, that what Dr. Hardik was saying previously, that this has also been included in their PCR kit. So Japanese encephalitis, we have seen number of outbreaks, fortunately not in Gujarat, but in West Bengal, Karnataka, Maharashtra, they have outbreaks. And the Japanese encephalitis vaccine is there in national program. So it is one of the most dreaded disease, which is fortunately not there in Ahmedabad or Gujarat, but we have to be very alert about this. Similarly, the enterovirus, the commonest cause of, I would say, enterovirus is the encephalitis enterovirus. The commonest sporadic cause is herpes simplex, and fortunately we have the acyclovir. This is the drug which is available. There is a treatable cause of encephalitis. In addition to that, we see lots of cases with dengue, H1N1 presenting as encephalitis and myocarditis. So dengue is no more now a simple disease. It often gets complicated with number of, including encephalomyelitis or even simple encephalitis. Now, rabies has already been discussed, and now the Chandipura virus, we have seen outbreaks in Andhra Pradesh, Gujarat, even the sporadic cases are there. And now Nipah virus, now before last week, we have got Nipah encephalitis in Kerala, etc. And again, we have got Nipah outbreak in 2001 in Siliguri and in West Bengal in 2000. So these are the common viral encephalitis that India is unfortunately wasting. But remember that the cerebral malaria, pathogenic meningitis, or tuberculosis meningitis, or scrub typhus can present with a similar complaint. That is similar pattern as like acute encephalitis syndrome. These microorganisms or these bugs are not going to read our textbook. They can present in any form, and therefore, whenever any child has got the acute encephalitis syndrome, these conditions are also to be ruled out because they have a specific therapy in terms of antimalarial, antibiotics, or even doxycycline. So it is very important that we may not miss any of the treatable cause of the encephalitis. Now, is it possible clinically that we are dealing with particular virus? Of course, we have got some clinical landmarks. So if there is a focal encephalitis, focal convulsion, or speech loss, probably it's the involvement of the frontotemporal, and we are probably dealing with case of HSV encephalitis. If there is cerebellar ataxia, it is very common with varicose zoster, that is chickenpox. If there is dementia, it is a sign usually featured with HIV and measles. If there is extrapyramidal manifestation like dystonia, rigidity, athetosis, then we can have a Japanese encephalitis, autoimmune encephalitis, or West Nile virus. If there is involvement of the eye in form of retinitis, it can be CMV or West Nile. If the rash is there, we can find it is measles, rubella, hand, foot, mouth disease, or even scab, where we can have the eschar. Remember, the presence of rash rules out Japanese encephalitis. I repeat, when the rash is there, it rules out Japanese encephalitis. So in Japanese encephalitis, we don't have any type of the rash. If there is diarrhea and respiratory or upper syndrome, you have to think of enterovirus. That is how we talk. We take nasopharyngeal swab for enterovirus. If there is respiratory involvement, it can be mycoplasma, adenovirus, influenza, H1N1, parotitis. We all know it can be mumps vulgaris. If there is lymphadenopathy, it can be HIV, Epstein-Barr virus, rubella, or West Nile. And if there is hepatitis, it can be hepatitis C, or it can be hepatitis C, hepatitis C, or even it can be leptospirosis. So these are the common clinical features which tells us about the predilection of that particular virus. Now, what investigation that I can provide? So the common investigation are common, that is CBC, ESR, peripheral sphere, especially for malaria, our CRP, LFT, RFT blood. So any child, when comes to you, this the basic is required. And if the epidemiology is going on or outbreak is going on, you can think of dengue, chikungunya, scrub. If there is family history of tuberculosis or if the TB elsewhere in the body in the past or presently, you can have TB workup in the form of X-ray test. You can go for the sputum. You can go for the CBNet or the GeneX from the appropriate sample. But what is important is that CSF examination, to send it for the routine culture and some specific test, and never ever forget to go for the fundus examination. And if the resources are available, I think neuroimaging can also be at your help. Now, one important thing that especially this Chandipura virus and Japanese virus, they are very dreaded. They are fulminant at the progress. So probably sometime you may not have a time to have a second sample. So the CSF is a very critical and very precious sample. So when you do a lumbar puncture, at least take 5 to 7 ml of the extra CSF and store it at 4 degrees for the PCR and the viral culture that can be sent to the Pune. So it is very important that you store the PCR, this CSF sample. Otherwise, you may not get the second chance. So if you look at this differential diagnosis of this, all these encephalitis syndrome, hemoglobin can be low in case of malaria, or it can be low in case of the rickettsia fever. Blood sugar is usually low in case of cerebral malaria. SGPT are usually elevated in case of viral encephalitis and mycoplasma because of a multi-system involvement. X-ray infiltrates are common with mycoplasma and with TB. And as far as MRI neuroimaging is concerned, a basal exudate, tuberculoma, and hydrocephalus is commonly with tuberculous meningitis, and involvement of the basal ganglia is common with JE encephalitis. And as far as the involvement of the area supplied by the middle cerebral artery is a very characteristic of the Chandipura encephalitis. And as far as CSF findings are concerned, again, there is the same slide, but as far as viral encephalitis is concerned, the protein may be normal or slightly raised. Cells are usually in hundreds, maybe 50. And in case of the mumps, the sugar may be low. So hypoglycemia is common in case of the mumps. In addition to the bacterial meningitis, as far as the tuberculous meningitis is concerned, I think the proteins are very high and sometimes it may get the cobweb formation. Now, what are the different specific tests? So always send a culture. Even if CSF fluid is clear, it is not that only turbid. Clear fluid also should be sent for the culture because the child might have received antibiotics previously. If you are suspecting tuberculosis meningitis, the same sample should be sent for the gene expert. A CSF test mainly for the Streptococcus pneumoniae, and multiplex PCR is now feasible and available. And CSF serology, even CSF, you can get dengue, IgM, IgM. You can call for the Chandipura IgM in the serology, chikungunya. So serology, CSF serology. So in addition to routine test, that is cell, biochemistry, protein, sugar, gram strain, always ask for the PCR and the specific serology depending on the outbreak you are facing in your community. Now these are the ME panel. This is the what we are using in the private. But remember, friends, do not send it left and right because it has got a large number of limitations. As far as our Indian epidemiology is concerned, it does not contain JE virus. It will not detect your dengue. It will not detect your H1N1. It will not detect your scrub typhus, and it will not detect your even Chandipura virus. So remember that this is a PCR which is developed by the developed country and is not is our nation friendly, and therefore we need to have our own PCR available in the country. So the neurology, the typical findings are there. When the basal ganglia are affected, it can be Japanese encephalitis. In case of ADM, there is a perivascular white matters are affected, and as HSV is concerned, the temporal lobe is commonly affected. So in HSV, a frontal lobe and temporal lobe are affected. For GE, basal ganglia affected. For varicella, white matter cerebellum affected. For polio, entire horn cell of the spinal cord affected. For mumps, it is the ependyma and the coron plexus are affected. For CME, there is walls of ventricles are affected. And for ABV, there may be some vasculitis. So these are the neurotropism. There, every organism has a predilection for a particular area in the brain. Maybe it is a gray matter or it can be a white matter. As far as the general management protocol, it is very important that you maintain the airway breathing circulation. Always there is an emergency, there should be an emergency for controlling the seizure. Otherwise, the child may not have the intact survival even if the child survives. You have to first collect the appropriate sample. If there is cerebral edema, you can give the mannitol or you can give 1 dose of the steroid if indicated. Maintain the hydration, maintain the euglycemia, and upfront you will start the acyclovir and ceftriaxone. If you are suspecting cerebral malaria, you can give IV artesunate, and if you are living in the area where scrub typhus is known, you can empirically or the doxycycline. So this is a very serious condition, and therefore you have to use a broad spectrum blanket coverage upfront. And once you arrive at a specific diagnosis, then you can omit the other drug and you rationalize the therapy and narrow down the therapy. So the specific therapy will depend upon the CSF finding and neuroimaging. If the diagnosis made, you continue specific therapy and omit others. You can stop the antibiotics if you have ruled out the pathogenic meningitis. If you have ruled out malaria, you can stop your artesunate. Similarly, if you have ruled out your herpes simplex, then you can stop the acyclovir. So that is how this specific therapy is there. Now, this is in general how we can address a case of fever with CNS manifestation. Now, the burning issue is that if you look at this 4-year pan-India survey, which is recently published in 2022 in Lancet, you can see that there are a number of causes, that is JEV, Japanese encephalitis, scrub, dengue, leptospira. But can someone ask them to mute, sir, Dr. Bhupendra, sir? Yeah. You will look at this. You look at this Gujarat. Let us consider this. Now, 20 suspected Chandipura virus deaths have been there, and this is the report from the last 20th July. So before 2 days. So this is the Chandipura virus that we are facing now, and you can see that the hospitals, the very sorry plight of scenario. And as discussed previously, I will not go much in the detail of a virus, but remember that this is the virus which has got a case fatality in the tune of 56 to 75%. So it is a highly fatal disease. It is a highly fatal disease. And most of the time, the disease has a sporadic form. However, it has got the potential for the epidemic as well. That is very important, that it can both sporadic, it can be there round the clock, round the year, but it can be a sporadic. And as of July, this is very alarming. As of July 2024, a total number of 78 cases of AES have been reported. Out of this 78, 75 from the Gujarat, and out of 28 deaths, whatever the 9 deaths have occurred, that occurred in Gujarat, and all these 9 deaths are because of the Chandipura virus. So remember that whatever the currently the child who has got the febrile encephalopathy, they are Chandipura virus unless proved otherwise. And the 9 out of 9 has expired in this. And the vector is sandfly. Again, I will not go in detail because it will already discussed, but they are usually found in the holes and cervices in the walls, holes in the trees, dark room, and stubbles. So this is very important that we can prevent these bleeding sites. The commonest age group which is affected is 9 months to 14 years. And if you look at the male-female ratio, male are more affected than female. Clinically, they present with high-grade fever. Now, for a practitioner point of view, it is very important for all of us. Every child will have a fever. Then how can I differentiate whether the child is having a fever because of Chandipura or whether it is a normal viral fever? So remember that in Chandipura virus, the fever is nearly 100%, 100 out of 100. If it is a common cold virus, if a flu virus, the fever may not be of that intensity. And that fever is always very high, 103, 104. Number two, in a common viral infection, if you give the paracetamol, child becomes playful within half an hour or in a 1 hour. And the interfebrile period child is usually good. As against this, in a Chandipura virus or in any potentially dangerous virus, child will not become completely normal. So even if the temperature comes down, child looks unusually weak, child looks unusually lethargic. And at times, this viral infection do not even respond to a dose of paracetamol. You have to repeat the doses, but still the child is not responding to the fever. Similarly, there is projectile vomiting, there may be diarrhea, sometimes there may be abdominal pain. Again, intense, the headache, and this headache can occur even in absence of fever. So that is very typical of the CNS syndrome. And in the second stage, the child becomes drowsy or irritable. So that is the stage of altered sensorium. And then child throws the convulsion. And if not taken care properly, he passes into decerebrate coma or the grade 4 coma, and within several undergoes the decerebrate posturing. And most of the time, they present the features up. So all this spectrum, all these events will occur from 12 hours to 96 hours. And the incubation period is nearly 12 to 24 hours. So this virus does not give much time to it. So especially if fever is there, if headache is there, if vomiting is there, this is a dangerous triad. Fever, vomiting, and headache. Always think of the CNS infection, number one. Second, if you're living in the area where this Chandipura virus has been detected, or if this area is notified, then remember that if you are living in the area which is 50 to 100 square yard in the nearby circumference, then all these cases, even though they don't have convulsion, even they are not unconscious, all these febrile children should be immediately brought into a surveillance. So that is very important. That is how can we early detect. So as a practitioner point of view, whenever the most important epidemiology, whether the case has been reported or not, and behavior of the child and response to the paracetamol is very, very important about because that is very important when how you can learn how to refer these cases early. Now, the rapid deterioration in these cases has not been much explained, but it is mainly because of the catastrophic event taking place in the brain. Sometimes it is also described as acute epidemic brain attack. This virus is also described as one of the important cause of the epidemic brain attack, and it's mainly because of the spasm or the transient obstruction of the vital vessel because of the vasculitis. And the most of the time, these pathological changes are seen in the cerebellum area, which is supplied by the middle cerebral artery. Another important feature in this that there may be marked hypoglycemia and very much rise of the SGPT. So this combination of hypoglycemia and increased SGPT, liver enzyme, sometimes it mimic like a case of Rett syndrome, but if you look at the pathology, it is quite different from the Rett syndrome. So sometimes clinically we may say that, oh, it's a case of Rett syndrome. No. Now we have a number of viruses that can present as a Rett syndrome like picture. So this is Chandipura is one virus where there is hypoglycemia, marked rise in the liver enzyme, and a fulminant progress. Now, this virus replicates in the neuronal cell, and there is rapid destruction of the cell because of the apoptosis, and this rapid replication and rapid or uncontrolled apoptosis at the cellular level is responsible for the fulminant course. Now, the samples that we have collected is a serum sample and CSF we already seen, and it has to be sent NIV, Pune, and now fortunately we have the facility at Gandhinagar. Serological test, that is IgM. Usually, remember that here again there is a catch. Most of the time the IgM antibody, though we say will appear by day 4, but sometimes the patient is so moribundly ill, we don't have any time. Before the antibody appear in the serum or in the CSF, child will succumb. So therefore, the IgM test is not a gold standard. If it is positive, it is positive, okay. But what is important that you have to go for the genetic material test, amplify the genetic, and that is by the confirmed genomic test by the PCR, and they have to detect GH in particular that primer has to be. So gold standard is the virus isolation. If it is not there, then I would say a silver standard is the typical symptomology, the area in which you are living. And the third one is the early detection with the help of the molecular test is very, very important. As far as CSF is concerned, it may be normal. There may be mild pleocytosis, again, a lymphocytic predominance. Proteins are often normal. So this mild pleocytosis and normal protein explains what? Indicates there is not significant necrosis of the ependyma, but it mainly says that it is a vascular event. So sometimes, most of the time, it's an acute vasculitis. Like in our liver, if the endothelial cells are affected, the SGPT is going to normal. So similarly, here in brain, the ependyma is not affected, and therefore protein and cellular reaction are not seen in CSF. Treatment is always supportive, airway breathing circulation, euglycemic control, seizure control, mannitol for the cerebral edema, and if there is hyperpyrexia, you can give paracetamol. If the child is not able to take orally, you can give it perrectally. Sometimes very high grade fever can respond to diclofenac, can also given as a perrectal examination. If there is a increase of tension is always there, therefore head elevation is very important. Mannitol should be given a loading dose 5 ml per kg, followed by 2 ml per kg. Hyperventilation and sometimes surgical decompression may be required in case of impending uncal herniation when the there is a refractory when the increase in the tension is refractory to our routine therapy. And it is very important from periphery or primary health center to ICU. The most important that always keep a high index of suspicion, and especially when you are living in the area where this Chandipura virus has started appearing, any febrile child should be under vigilance. Any unexplained death in the community should be alert. And all this close contact, even with the minor of the minor symptoms, should be kept under surveillance and the vigilance. Otherwise, you will miss, and it will be too late. So, if there is you have to maintain the airway. So, we are now number of CPR courses are there. We have keep a bandage near the shoulder and keep the airway maintainable. That is more important. Number one, control of the seizure. Now you may not have a IV access, but you can have number of preparations are available, which can be given as suppository. We have number spray, Mira spray, which can be given nasally, which can be given buccally, which can abort the convulsion. Paracetamol, if not orally, you can give suppository for the fever, hyperexia. Always give the first dose antibiotic given intramuscularly. It will save the life of the patient, and a good referral note at a good hospital is very, very important. So that is all about from my side. So prognosis in survivor, there will be complete recovery. So it's this Chandipura virus is a all or none law. If the good facility is available, if good medical care is available, the child will survive. But those who survive, they don't have any morbidity. They won't have a post-convulsive epilepsy, post-epilepsy. They don't have any paralysis. They don't have any speech problem. So there is complete neurological recovery. But those who do not survive, but those who do not respond will die within 40 to 96 hours. So the prognosis follows the all or none law. And preventive measures, of course, health education, most important, insecticide, DDT, and 5% malathion, use of the repellent net. You can have a fly paper, a full sleeve clothes, avoid water clogging, repair of the cracks in the house and huts, and vaccines are under clinical. And it's important, once you find the Chandipura virus, nearly 50 yards of the breeding places. So once breeding places is identified, the surrounding 50 yards area should be kept under surveillance, both from the sample surveying as well as from the point of insecticide and the malathion spraying. And health is important. We have got different vaccine, recombinant vaccine and kill vaccine. They are awaiting for the clinical trials, and let us hope for the best. And last one, the challenges are that the paucity of the data, there is no epidemic record, lack of visibility, lack of point of care test, lack of ICU in the periphery, lack of facility and neuroimaging, and patient delay in signature and inappropriate supportive care. So the crux is that the supportive care is the most important. And once you stabilize the patient and send the patient to the higher center, probably 50% of they can be survived. So with this, I thank organizers for the wonderful opportunity. Thank you so much. If you have any question, I will be happy to answer that.
Sir, there are two questions reflecting on the screen.
Yeah.
One is why urine sample sent, and second one is there any lesion can be seen at the site of bite?
Yeah, so the urine sample is mainly some of the viruses are also active in urine. So sometimes the CSF is not possible. Sometimes we can send the urine sample. And it's, this site of bite is a question of luck, just like a lottery. If you are living in the area where the Chandipura virus is prevalent, and if the bite is there and the child is fever, I think but it is not always there. It is not always there. Suppose if there is a tick bite, then it is there. But as a sandfly bite is concerned, it is very difficult. It is very difficult to identify.
Any other question from the audience?
Dr. Abhay Bhai.
Yeah.
First thing, excellent discussion by both the speakers and practically covered everything. My only question, more of a query and that more theoretical because I'm not a pediatrician or dealing with patients, is that as you said that the recovery is 100% those who survive. That means it is something which is more of a reversible pathologies, or maybe said there is a cytokine storm just what we saw in COVID. So can we have surrogate markers like IL-6 1, and can we give drugs like tocilizumab or something which might tide over the cytokine storm? And
yeah, sir, it's a very good question. See, though this virus is so much prevalent, I would say the limitation or the hard luck that this has not been covered under the surveillance of the acute encephalomyelitis syndrome, even by WHO, number one. Second, the virus has not been much studied, number two. Number three, whatever the post-mortem reports are there, they are the findings are not consistent all the autopsy. Number four, only thing that the cytokine storm is there because the progress is fulminant. And whatever the MRI findings are, there is a huge cerebral edema, especially in the middle cerebral artery. But if you look at the LDH level, if you look at the SGPT level, if you look at the multi-system involvement, I think there are all the possibilities that yes, it has a possibility of cytokine storm. That is number one. Now, second, whether this cytokine is suppressed by this our monoclonal antibody, it's an area of research. So I cannot, from this platform, at least I cannot say yes or no. But of course, every virus has a different type of cytokine storm. And for that different cytokine, we have a different monoclonal antibody. So we cannot have a blanket coverage that where visiting COVID means this should work in this also. It's not like that, sir.
Right. The idea was only one, that as we see in COVID also, that there is a very small window for steroids and small window for cytokine storms. If we can pick up this, probably we may save few lives.
No. But what we have started doing this, of course, I have not seen any Chandipura, but whenever this such type of cases there, we use usually IVIG. We usually give IVIG. And sometimes we go for the plasmapheresis.
Any more questions, sir? Anyone?
Yes, sir, one question from my side. Yeah, Dr. Abhay Bhai, whatever sample right now we are sending is of a patient who are already having a CNS manifestations. Probably that is why we are having 100% fatality. So if the child presents with only high-grade fever with headache, fever not subsiding, even with paracetamol, should we send a sample of those patients?
That I emphasize 3 times in the talk, that if you are living in the area where the Chandipura is known to occur, or the one case has been notified, and especially you are living in the 50-yard circle of that particular area.
Apart from, for example, I am living in Rajkot.
No, it's not needed. No, that much is not needed.
Okay.
That much is not needed. It will be too much.
Only positive cases occurred in a nearby area, only then.
In a notified area, or if the child has a typical triad, fever, vomiting, and headache. Not only simple fever.
Fever, vomiting, headache without CNS manifestation.
Why to take chance? Of course.
Yeah.
And
excellent talk, Dr. Abhay Bhai. Thank you.
And what Dr. Hardik has said is very pertinent. So we cannot just focus only on Chandipura.
That's true.
All the vectors has the right to transmit any disease. And someone like Chandipura, some other like enterovirus. So I think that kit, which is I think our nation friendly, should be used. So all these four are important viruses that are included in that kit is very important. It's a very good move from the government.
Thank you very much, sir, for such an informative lecture. Thank you all, both the speakers, Dr. Hardik Bhavsar sir and Dr. Abhay Shah sir, for sparing the time for us. And thank you, our dignitaries, our respected Dr. Jaswant Darbar, Director of the CGP, Dr. Mahadev Desai sir, Dr. Kakaria sir, the President of IMA GSB, Dr. Mehul Shah sir, the Honorary Secretary of the IMA GSB, and our very senior pediatrician from the Rajkot, Dr. Yagnesh Popat sir, and all the audience who have joined online with us for such a beautiful session. Thank you, everyone. Again, thank you. So we are concluding our session. Anything left, sir?
Thank you.
Thank you. As Dinesh Bhai said, they will be conclude the session. My request to all our this primary healthcare worker, particular family physician, and whosoever are watching this webinar, which is enlightened by our two most prominent and well-known speaker. This knowledge we have to percolate to the society, and particularly we are the person who can prevent the disease because this is a vector-borne disease, so we can prevent the disease. As this, it has got, I think, almost 50% mortality. Thank you all.
Thank you. Thank you.
Okay.
So we'll leave the session. Okay.
Thank you. Thanks.
Thank you.
Bye. Thank you.
Thank you, Abhay.
Bye.
Yeah.
Thank you. Bye.